Welcome to TCN Talks. The goal of our podcast is to provide concise and relevant information for busy hospice and palliative care leaders and staff. We understand your busy schedules and believe that brevity signals respect. And now, here's our host, Chris Como.
Welcome to TCN Talks. I'm so excited today. This is a show, we're going to call it The Future of Alzheimer's and Dementia Care. And this is a show I've been working on for a while. So I have two great people to introduce you to. First, Stelley Gutman, who's a physician with MemoryCare. Welcome, Stelley. It's so good to have you.
Yeah, thanks so much for having us.
And she has also invited Elizabeth Lackey. She's the lead care manager with MemoryCare as well. Welcome,
Thank you. So
Elizabeth.
happy to be here.
Well, first, Dr. Gutman, if you'll just share with the audience, what do they need to know about you?
Well, I am an internal medicine doctor by training. I have really always known that I wanted to do geriatrics. I spent a ton of time with my grandparents growing up and just have always gravitated towards the elderly and had a passion there. And then through geriatrics, I really developed a passion for palliative care as well. I feel like they go so hand in hand. And so I did training in both geriatrics and palliative care. And now I'm lucky enough to have a job where I get to combine those two passions. Now I work as a dementia specialist in Asheville at a clinic called MemoryCare. And I see patients with dementia and support their families. And I do feel like it's the ultimate combination of geriatrics and palliative care.
That's awesome. So where did you do your palliative care work?
Oh, my training was at Brown. I did both geriatrics and palliative care fellowships at Brown.
Did you know Dr. Joantino?
She was a little before my time, but I think she had just moved. I think she moved on the West Coast, right? She went from Brown to somewhere on the West Coast, but she did that just before I came. But I heard about her. She's very famous.
Yeah, very famous researcher, and just talk about from a research perspective is well known. Well, Elizabeth, what does our audience need to know about you?
Yeah, so I'm a master's level social worker, and really unlike Dr. Gutman, I did not start out as a young person with a real passion for working with older adults. But what really kind of flipped the switch for me was coming into MemoryCare just as a learning opportunity. I interned here in college, and I was introduced very young to this sort of model of a deep level of cooperation, respect, and support with working with families. And I was really quickly won over with how important it is, not only for the family, but for the patient to have this level of really wraparound care and supporting families and doing what is a 24/7, 365 job. It's one of the hardest jobs out there. And I get so much satisfaction out of helping families find joy and peace in working with this disease, because it really is a whole family disease.
Well, and in a second, I'm going to have you guys describe, so what is MemoryCare, but just quick context for the listeners. Dr. John Morris was the longtime palliative care medical director at Four Seasons. John was actually my first hire. His wife, Dr. Peggy Knoll, was the founder of MemoryCare. And what always struck me, because I've kind of grown up now 28 years in hospice, especially nonprofit hospice, that there's just this amazing mission and heart behind the work. And so John and I got to journey that at Four Seasons, but at the same time, I saw Peggy journeying that with MemoryCare, and the parallels of just the passion, the values, the innovativeness. So I've just always been an admirer, but just tell our listeners a little bit about what is MemoryCare, the SEC, so it's the State Employees Credit Union Center for MemoryCare. So just a little bit about the history and where you guys work.
Yeah, so I mean, it truly does start out with Dr. Peggy Knoll, our founder. She's just a truly amazing woman. And years ago, she was working as a geriatrician here in Asheville, and she found that a lot of her practice was managing dementia, and she realized that working closely with families and caregivers, in addition to focusing on patients, really gave the best care. But unfortunately, that kind of high quality care doesn't get reimbursed. So she ended up losing her funding when she was working for another entity in town. So she is just so amazing. In order to keep seeing her patients and keep offering that great care, she had a pretty innovative idea to form a nonprofit charitable organization that would serve patients with dementia and their caregivers. So she founded MemoryCare in the year 2000. And I think, she will tell you that she wasn't sure that it was going to work. She didn't really know how long she could keep it going. I think when she first started, she was operating out of donated space, and they tell stories about how they saw patients in like a kitchenette, or I think at one point they saw patients in a janitor's closet. But it really did work, and I think the community saw the value and has supported MemoryCare's growth beautifully. And now it's a thriving clinic with 7 providers, and I think we do really great work here. It's innovative, I think, because in addition to diagnosing and medically managing people with dementia, this model that she came up with, it really focuses heavily on also supporting and educating caregivers who bear so much of the burden of dementia. Here we operate in teams. So typically it's a provider who's paired with a care manager. Like for example, while I am in a room with a patient talking and examining, the care manager that's my partner is usually in a separate room with a caregiver talking about like resources that we think would be a good fit for them, supporting them through whatever they happen to be going through. And we're set up to have more time than primary care offices are set up for, and we're just able to provide more support and resources for these people who really, really need it. But that caregiver support piece historically has not been something that our medical system deems worthy of compensation. So, all the time that we spend educating and supporting caregivers isn't something that historically insurance has paid for. So we do have to raise about 50% of our budget through grants and through charitable donations.
Wow. I don't know if you know this, Stelley, but so I got to go spend some time in England. That's where hospice was founded, the modern day hospice movement, St. Christopher's in London. In about 2018, a group of us got invited to go across the pond, as they say. So we're sitting with all the people within England. So hospice and palliative care all is one, and their NHS, which is their version of Medicare, only funds about 50%. So they have to do the same thing. If you ever go to England and you wonder why there's a hospice thrift store in every village in town, that's because that's necessary for them for their fundraising aspect. So I totally did not know that about your percentage. Well, I'm going to share some statistics. I want to get into some more discussions, but thanks for all that, because it just shows there's so many parallels between kind of your organization in the early days of hospice. Now, we do have the benefit that we rely upon now. 95% of our funding is kind of covered by Medicare. Mm-hmm. My concern is our future might be more like you guys, where it's going to get tougher and tougher to do what we do today. But as I was doing show prep, I just started looking at some statistics, and were pretty startling to me. About 7 million people today are living with Alzheimer's dementia care. It's about 1 in 9 people that are greater than 65 years or older. It's now currently in the top 10 leading causes of death today, but is predicted by 2030 it'll be in the top 4. And then just in prep, I just wanted to share with you guys some of the articles I just started just being more cognizant, knowing that we're going to talk about Alzheimer's and dementia care. So this was in McKnight. So adding a lifestyle coach to treatment decreases cognitive decline in early Alzheimer's. Dementia diagnosis causes out-of-pocket spending to skyrocket and net worth to plummet. So my guess is these are exactly the things that you guys see. Why we've got Elizabeth with us, one of the really cool things is we're going to talk about where palliative care fits into CMMI's guide model for dementia care. So this guide model, and there's going to be a lot more coming out pretty close to the time that this show will probably be airing about that. So we're kind of excited about that. Let's see here. New dementia telehealth program cuts costs and boosts quality of life. As dementia increases, action is needed just by more and more people in the community. Limiting hospice care for dementia patients over cost is liable to backfire. There's a lot of, dementia patients are the hardest to prognosticate. And then so they tend to have longer lengths of stay. So there's a lot of people asking, is hospice really the best model for people with dementia care? CMS unveils program to improve dementia care, ease unpaid caregiver strain. Let's see here. This is by MPHI, Quality of Life for Dementia Patients and Their Caregiver. It's a guide that MPHI just actually released, which is great. And then Senior Living, $4 billion increase in Alzheimer's funded needed to prevent catastrophe. Is just interesting article. So there's just so much interesting stuff that obviously as we go forward into the future and just the demographics as we're going to see more people. So I'm just curious as if any comments, Stelley, as I kind of shared some of those articles, anything that kind of jumped out at you as you saw those and the world that you live in on a day-to-day basis?
Yeah, I mean, I do think the one that was about Florida, I thought was really interesting. There was one that you sent that that was just talking about what a crisis they're going to reach because it's so many people who've moved away from their family to retire to Florida, and then as they age, and in general in the U.S. as we have an aging population and the baby boomers are aging, we expect this big boom of Alzheimer's and dementia. And it is going to be a crisis because our system is just really not set up to support that. So I think it's good that there's more press about it, and it seems like people are starting to get the urgency of that. And hopefully, especially with like the guide model, hopefully we'll start to put something in place to help support that boom.
Well, this is actually very similar. Again, I didn't anticipate all the parallels between those of us kind of grown up in hospice to where you guys are journeying now. But considering all those startling statistics, my guess is that you guys are seeing some innovations that are coming. Maybe even you guys are even spearheading or providing yourself. So can you speak to those?
Yeah, I mean, I do think it's an exciting time to be a dementia specialist right now. There's been a lot of innovation to the science, which is cool. One of the big things that I think is going to make a change is we're getting better testing. Historically, Alzheimer's and dementia, they're diagnoses that you make just based on like the clinical picture. We didn't really have any readily available tests to get a definitive diagnosis. And actually in the last year, we had testing become available that is peripheral blood testing, really easy to obtain, that tests for biomarkers. So, blood tests that can really show these biomarkers that can tell you whether or not you have evidence of the pathology of Alzheimer's, which I think is going to, as it becomes more popular, I think that is going to be really big. I think it will probably lead to people being diagnosed with Alzheimer's earlier on in the disease process, and also just having more of a definitive diagnosis. We also have seen, the rollout of some newer medications, which has been big. Over the last couple of years, there's been development and approval by the FDA of new meds, the monoclonal antibodies you probably heard about in the news, the medicines that bind to amyloid plaque, which is really the hallmark of Alzheimer's, and remove it from the brain. So aducanumab was the first one and was the most controversial probably. Now we have lecanemab. Soon we will have donanemab as well. And these are the first meds that have been approved for Alzheimer's in 20 years or so. So it's, they're not curative medications by any means. They certainly have their limitations and their risks. But I do think most of us are hopeful that these medicines might serve as a stepping stone towards more medications with greater efficacy in the future. And then the other thing that we really see and we are trying to focus on is the evidence that we all have the power to reduce our risk for developing dementia by making changes to our lifestyle. I think one of the articles that you sent talked about this, but yeah, there's more research to show this, and the Lancet Commission actually did a really extensive review of the evidence for dementia prevention to find that 40% of dementia incidents could be prevented by making changes to modifiable risk factors, which is it's good. I mean, it's like good information to have. Hopefully that can help us moving forward to educate people and move the needle a little bit earlier on before people are developing.
Thank you to our TCN Talks sponsor, Delta Care RX. Delta Care RX is also the title sponsor for our May and November 2023 Leadership Immersion courses. Delta Care RX is primarily known as a national hospice, PBM, and prescription mail order company. Delta Care RX is a premier vendor of TCN and provides not only pharmaceutical care, but also niche software innovations that save their customers time, stress, and money. Thank you, Delta Care RX, for all the great work you do in end-of-life and serious illness care.
Dr. Gutman, have you ever read Dr. Peter Attia's book? He's out at Stanford, Outlive. Have you bumped into that book?
I haven't read the book, but I do listen to his podcast also.
He's amazing. Yeah. That book is amazing. And go ahead, Elizabeth.
I'm our resource coordinator here and our librarian for our free library here, and I just ordered a few copies of that book. So they are prominently featured right now in my new availabilities in the library.
Fair warning, it is a very dense read, and a lot of people know I'm a bit of a geek, but I've recommended that book to so many people, and it's interesting. It'll be a good lead-in to a question I want to ask you, Dr. Gutman. That I love the phraseology. He says going from medicine 2.0 to more 3.0, which is much more of a proactive approach. And so much of medicine today is reactive. So if you can screen earlier and know that you have the propensity, Dr. Gutman, you might have to help me. Is it the APOE gene? APOE? How do you say it?
APOE. Yep.
APOE. And then what do you do once you have it? But then good, healthy lifestyle, eating well, exercise, all the things we've always known that it can forestall is his hypothesis. So instead of waiting till people in crisis stage. So as you were talking, I didn't think about this before, but do you have a certain stage when people could become part of your program? Like what if someone was diagnosed in their early 50s, but they're still, they're not showing any signs or symptoms, or maybe just very early. Like in hospice, we know prognosis 6 months or less. Do you guys have some type of line of demarcation when someone qualifies for your program?
No, we really accept, we will see anyone. So all that people need to do to come here is to just have a referral from their primary care doctor, really. We often will see people who are pretty young, and it's not that we only see people who have a diagnosis of dementia. Often we are seeing people who are just complaining of some memory loss, some cognitive issues, and we are having them come here and do a full evaluation so that we can try to understand what may be causing their changes to memory. So we do sometimes see people who are young. Obviously, mostly we see people who are over 65 because that's just the nature of the disease, but there's no cutoff.
So is your approach more curative or palliative, or both?
Well, I would say in general for dementia care right now, the approach tends to be more palliative. Every once in a while, I have had someone who will come in for an evaluation and maybe they don't end up having dementia. Sometimes, it may be, we make some adjustments to medications. I've had somebody who had, really bad sleep apnea that wasn't being treated. So we were able to identify that and treat it. And then they ended up having a fine memory and good cognition. So very rarely we'll get something like that, that feels, curative in nature. But for the most part, there really is no cure for dementia. And so most of our care is palliative in that way, that we sort of support people along their journey and support their caregivers along the journey and try to do everything that we can to make that process, livable, to make it, as good as it can be for as long as it can be.
Do you have a general average length of stay that your clients are with you? I imagine it's probably years.
I don't know what our general, Elizabeth, do you have any idea what our length of stay average?
I don't know that we take that statistic, but I think that's an interesting one. But I mean, it so depends on the patient. Sometimes we have folks who come in and, they see us for a year or two and they feel like, I understand what this is now and what this is going to be, and that's what we need. And then, gosh, I working with some of our docs, we have people who have been, in our clinic and in our lives for almost a decade. And sometimes you are just really walking with that person from the very, very beginning to the very end. And it is it's a hard privilege, but such a privilege to be able to do that when that feels like a really good fit, because there's so much support and trust in that relationship when you know that this doctor is going to be with you through every stage of the disease process.
Well, that's probably a good segue, Elizabeth. So let's talk about the guide model. Really interesting. I have no idea if you guys influenced it. And so my guess is that some way you probably did, and maybe are. In fact, I think you guys may have gotten visited by, I don't know if it was CMMI or CMS, but love to hear. What do you think are the positive potentials and what maybe are the challenges?
Yeah, and this may be the social worker in me talking, which is often, but, really personally, I'm more excited about the guide model as a support to families than, most of the new MAB drugs. And I think that just in our particular clientele, we have a lot of folks who aren't, maybe appropriate candidates for the MABs for a whole variety of reasons, whether that be expense or how progressed somebody already is in their disease process, or even just the burden of having to go get infusions and accessibility to those things. And so from my perspective, I'm really focused on, family care. What can we do now to really help and support people who might have already been going through this journey for years at this point. And what the guide model is offering is Medicare reimbursement to be able to help pay caregivers, to help pay for caregiver support, and really help get them more access to rest and respite that they deserve. Something that I think can occasionally be left out of these types of conversations is the true health impact that caregiving has on caregivers. Like I said, it's a 24/7, 365 job. And I think we talk more as a community now about toxic stress and the types of things that prolonged stress can do to our bodies. And we know from research that caregivers are more prone to some chronic health conditions due to the stress of caregiving. And it is not at all to place that burden on the patient. We say it's a family disease because it takes a village to help support a person through dementia, as well as we should be able to provide a village for our folks who are doing that caregiving work. And as providers, I think we are often left scratching our heads to really know what we can offer and what we can support to patients in that real hands-on, helpful way. And so for us, I'm so excited about the guide program, because that's going to allow us, if we are able to work within that parameter, to be able to offer real solutions of, here is funding for you. If you qualify for the guide program, families are eligible for up to $2,500 of respite care annually. So that can be used in home care provision. So really having folks come into the home, helping with the patient, allowing the time for the caregiver to do anything else that they need to do in their own lives. Hopefully even attending their own doctor's appointments. I think that's something I get on my families about, hey, you're doing so great doing these doctor's appointments, for your loved one. When was the last time you went? What are you doing for you? So I think that the guide program offers so much potential for families to have the support that they have needed for so long. Dr. Gutman and I were discussing this ahead of time. I think that palliative and hospice care providers are really uniquely positioned to take advantage of the model because the infrastructure is already there. Part of the guide requirements is that the patient has to have a home visit within 2 months of enrollment in the program. And so for people like primary care providers, this is going to be a really big shift. If they want to take on this model, it's going to be a really big shift in how they practice. I assume you're going to have to hire, a totally new position to manage these home visits and get the data collection set up and all this. But for palliative and hospice care providers, y'all are already in the home. You're already providing that, more frequent check-in support than primary care practice, and you're already in the home. So to be able, from a provider perspective, being able to participate in the program and fulfilling the requirements that CMMI is asking people to participate in so that they can provide this respite funding. I think palliative and hospice care providers are really have a leg up in, if that feels like a good fit for them, engaging with that model as the government has so far put out that this is how we need to participate in it.
And it's a demonstration because it's CMMI, Centers for Medicare and Medicaid Innovation, and potentially are we thinking it'll be deployed in 24?
So what we have heard is that they're going to release some more information to really give practices the information they need to decide whether or not they can participate in it. We've heard late winter 2024, and as far as we know, it is supposed to get off the ground July 2024 in terms of implementation, so people can start enrolling people into Guide in their practices, getting that infrastructure set up, and kind of doing that preliminary billing in July 2024.
And I think, did I read as potentially an 8-year demonstration?
Yes. We have been told it has been. I know that things always change. President to president. It's never. Gosh, guaranteed, which is kind of the scary thing about, I'm sure for them and for everybody participating, but we've been told that, yes, it's an 8-year project, and that funding, since it has been acquired at this point, seems to be pretty as set in stone as these things can be.
Well, let's kind of segue, and we'll land the plane in just a little bit here. But so now more the hospice side, and this is where there's this is originally the reason why I wanted to do this show. The more, I'm not trained as a clinician, but the more that I understand, I've had a family member recently dealing with Alzheimer's dementia. It's my godfather, his wife, and there's just a lot of different varying views. Is hospice the best model when people are at the end of life? And so I'm curious, is there a better model for Alzheimer's patients needing end-of-life care? It's pretty interesting. We've always had this amazing relationship for seasons, MemoryCare. It's pretty interesting. We had Dr. Morris and his wife. It's probably some reason why we've had such a good kind of coexisting relationship, but I'd love to hear your opinion about that.
Yeah, I definitely think that hospice for our patients is a lifesaver. Like when they enroll and when they're able to get hospice care, it is truly, truly helpful. I do think there are some issues. I see a glimmer of hope in the Guide model. I think to me that's evidence that like CMS and our government leaders, they see that dementia is a major issue. They see that supporting caregivers is key. I think the best thing that hospice does is support caregivers really well. So that feels like a change to me. It makes me hopeful. I would love it if CMS, if there could be a change for hospice eligibility. I think one of the issues I have is like the hospice eligibility criteria for our dementia patients doesn't really make that much sense to me. I think, we were saying earlier, hospice really was developed for people with more of an acute illness.
Yep.
It really wasn't built for the prolonged gradual progression that we most commonly see with dementia. And then because of that strict eligibility criteria and really, really tough to prognosticate in dementia. So I do think there are a lot of dementia patients who miss out on the hospice benefit. I see a lot of families who are really comfort focused and their loved one is pretty progressive, but they're just not quite severe enough to meet hospice criteria. And they'll tell us like, as soon as we're eligible for hospice, I do want to enroll, but they end up waiting for that support and they really need it. Like they're drowning in caregiving duties and they really could use more support. And then some of the people that we do get enrolled on hospice later get discharged if they don't find fast enough, which is so hard on families. And So I would love to see a model of hospice or some sort of model where dementia patients in a more moderate to severe stage could get some type of support, whether that be hospice support, like a hospice light, or maybe if the palliative care groups found a footing with the guide program and this seemed to work out well, it may look more like palliative care plus. But I do think there's just that population, especially in the moderate to severe stage of dementia, who get ignored by our medical system currently. And I'd love to see people not, get discharged from hospice when they have dementia.
Yeah. Do you know the background of where they came up with the 6-month prognosis?
No.
So this will be fascinating for you. I'm a history geek, and so I was reading something the other day, and this is such a corollary to hospice 6-month diagnosis. The DMZ in North Korea was literally some guy at a map late at night going, we got to figure out a boundary, and he picked a boundary. The hospice 6-month prognosis is it was the literally 12th hour. You're going to get a Medicare benefit. And they said, holy crap, we can't leave this open-ended. We've got to create a time limitation, 6 months. And that's literally not research, wasn't database. It was, we got to come up with something. And so someone said, you know what, 6-month prognosis. And that's literally now 40 years later what we're living with. And you think about Alzheimer's, dementia, even how cancer has. So yeah, that's the background. So I think that's very well said. And you can imagine the government's figured out they make $5 for every $1 in audits. So these hospices are getting all these audits and said, well, this patient didn't die. And that's why you're seeing this horrible pressure on the discharge side. So, well, any final advice? I mean, you guys have the ear of hospice and palliative care leaders. Any final thoughts or advice that you'd like to share with them?
I would just say how much our patients and their families appreciate and need the support of hospice. For us, the average prognosis for somebody after they're diagnosed with Alzheimer's is, 8 to 10 years. So we see these caregivers who have been taking care of their spouse or their parent with dementia for years, sometimes like 15 years, and they generally have very little support. And, as Elizabeth said, the toll that takes on these people is enormous. The caregiver burnout that we see it's so sad, and it's really hard. And then when they do enroll on hospice, the feedback that I get is always so positive. They are so appreciative to have some of that burden be carried by somebody else, and to have it covered. So I think moving forward, anything that we can do to reach more families struggling with dementia would be great. And thank you for what you do.
Well, thank you for both of what you do. And I'm sitting here reflecting, going, we're like this is your people. Like the people live, like we're all part of the same tribe here. And like what we would say, and maybe it's a little bit of, hopefully it doesn't come across as arrogance, but I feel like you guys have what we would call that hospice and palliative care heart. It's so obvious in the work that both of you guys are doing. And maybe the better way to say is that you're such mission-centered people, and that this is your tribe, is the hospice and palliative care people that are listening to this podcast. So thanks to the great work that you guys do and all of your team. There's so many interesting ideas I've had of been listening to you guys. I just had this sense this would be a really good show. I think it's important for hospice and palliative care people to realize that there are other people out there that are as mission-centered. And I wonder how much just the fact that it was Dr. Morris and his wife that we've had this natural collaboration. Some people in some communities might look at it as kind of a co-opetition situation. No, when you're looking at scarce resources, just that heart of collaboration is so important. So again, just want to give you guys kudos for the great work that you're doing, and the fact that you have to fundraise 50% of what you do. Man, that does remind me of a lot of our roots. I mean, originally hospice, there was no Medicare benefit. So it was 100% fundraised in the early days. So in some respects, you've also got brothers and sisters here on the hospice side who've kind of journeyed this. There's probably some interesting learning lessons as you guys continue to go forward and do the great work that you do. So again, thank you. And to our listeners, I want to close with a quote. This one is for the long time, he was the president and CEO of NOC, Val Hamaderis, who's now passed on. He said, aging is inevitable and demography is destiny. Thanks for listening to TCN Talks.